welcome to our event, The Intersection. I'm Gretchen Parsons. I'm the managing editor of Boise Dev. I also bring you your morning Boise Dev AM newsletter. We've got a great hour planned for you, and we'll have you out the door today by 5 p.m. If you haven't yet, please make sure to grab a beverage in the back from our friends at Free Spirits Beverage Co. They have some non-alcoholic mocktails. I just tried one. They're really good, so please get one if you haven't. Our sponsors for the intersection are Regents Blue Shield of Idaho and St. Alphonsus Health System. Regents has been the longtime presenting sponsor of Boise Dev, a long-term partnership that was established in 2020, and their support has been a big reason why we've been able to bring you guys so many stories over the years. So big thank you. Also, new this year is St. Alphonsus Health System. They're sponsoring today's event, and they're also sponsoring our event, Peak 43, which is later this fall. So we really appreciate their support as well. And as we all know, the cost of healthcare is increasing. But are there ways that insurance companies, providers, business owners, and individuals can work to keep these costs in check? And what role does cost play in the overall picture of healthcare? Well, we've got two great guests to talk about this, and I'll let our senior reporter, Margaret Carmel, introduce them.
Thanks, Gretchen. It's great to be here. Our guests today are Ed Castledine with St. Alphonsus Health System and Dr. Dan Meltzer with Regents Blue Shield of Idaho. Ed is the Vice President of Corporate and Insurance and Broker Relations for St. Alphonsus. His previous roles include CEO of Salzer Health, Market President of Select Health in Idaho, and CEO of St. Luke's Nampa Hospital. He is a Nampa native and holds degrees from Mount Vernon Nazarene University in Ohio and Northwest Nazarene University in Nampa. Dan is the Executive Medical Director for Regents. His past roles include as Chief Medical Officer and Senior Vice President of Matrix Medical Network in Scottsdale, Arizona, and Chief of the Department of Emergency Medicine at Kaiser Permanente in San Diego. He's also an active clinical care provider here in the area. He holds an MD from Boston University in Massachusetts.
Go Terriers.
Welcome, guys. I really appreciate you taking the time to be here with us today.
Thank you. Happy to be here.
To start off, healthcare costs have been rising for years, as we all know by looking at our bills. There's a lot of conversations about how to make it affordable. How are you guys working either together or separately to bring prices down?
Ed's looking at me. I told him I'm not going to wrestle him, so I'll start. I think the first thing as I was thinking about this is that it's really hard to decouple or uncouple cost with quality and access. So when we think about sort of the three-legged stool, and even though we're sitting on four-legged ones, that's the dynamic that we have to all sort of contend with, right? And there's sort of the old joke that, quality, affordability, and access pick two, right? We'd love to have affordable, high quality, and accessible care for everyone, but in general, they're sort of diametrically opposed. So that's just an inherent dynamic that we think about. So as we here today specifically address the affordability piece, you're right, there's no doubt, as is the case with just about anything these days, costs are going up. And the reasons for healthcare are obviously multifactorial. What I love about Boise and our partnership in particular is that we're in it together. First of all of us are patients, and that's kind of what I come back to at one time or another. All of us are patients, people that we love may be currently active in care. So how can we work together to make it affordable? Because it's great if you have access and quality, but if you can't afford it, who cares? I think there's a couple general things that we tend to work on. First of all, I'm very mindful of our role as a payer is to be an enabler of care. We don't typically deliver care, so we want to ensure that the physicians like myself and others who are delivering it have as little headwind as possible to do their jobs, meaning sure that they're getting paid, the systems for whom they work getting paid. So managing risk and managing claims efficiently is what most of us want from our healthcare companies. The way that we do that in terms of affordability is multifactorial. One is always ensuring that the care that's being delivered for our members is evidence-based. If you follow the evidence, you reduce waste and variability, and you improve quality and affordability. The other is to work with partners such as Ed and others. Shout out to Luke's as well in the room, is how physicians are paid, where care is delivered, working on things where we have a lot of common ground and shared purpose, such as access to primary care, and certainly medications is another big issue. How can we work collectively to reduce the price of drugs that so many of us depend on? I'll start there with high-level stuff.
Great.
So I think the only thing I'll add to that is, and maybe it's a little bit divergent from where we were in the past, is health insurance companies and the health systems are actually working together now. So we're communicating more. We're sharing data. We're seeking out the other one's opinion on things. We've called each other partners for decades. I think it's only been in the recent few years that we're actually starting to act like partners, which sounds funny to a lot of different industries, but there hasn't been a lot of motivation for us to actually be partners until the last 5 years or so. And so that's a really significant evolution in healthcare, in my opinion. And what it leads to is when you get better communication, you get better data, and that data can be used to make decisions that are going to be in the best interests of members and patients. And so, for me, that's the most significant evolution over the past several years.
As a statewide insurer, Dr. Meltzer, what steps are you taking to reduce costs for both patients and employers? Do you have any successful programs that you can point to?
Yeah, I mean, there are innumerable ones. I think I'll start with, talk about sort of the common enemy. Even though I don't like to talk about pharma as an enemy because most of us would not be alive if it weren't for certain medications. But I think, there's no doubt that the escalation in price of medications has increased. And some of that is because we've just seen incredible scientific developments in certain medications for difficult to treat diseases like cancer and autoimmune diseases. What we've seen is a shift, not to get overly clinical, from sort of simple molecule medications, think Tylenol and aspirin, to what we call biologics. And one of the things that we've been able to do as a health plan is, with the advent of these medications, move most of our members, about 95%, to what are called biosimilars. Same medication, if you will. Now it's more of a generic version. We don't call it a generic, we call it a biosimilar. So 95% of our medications will get the same effectiveness, the same safety at a fraction of the price. And we've saved about $37 million for our members just in the past year switching to biosimilars. Another one is again, working with partners such as Ed and others, is to ensure at the time of sign up that members have access to primary care, that they're assigned and attributed, if you will, to a primary care physician, because we know that good things happen when you have a primary care physician, and other things like, dare I say, you end up in the emergency department in front of me, more often than not is either I couldn't get into my primary care physician or I don't have one. So working to ensure primary care, we've seen that when our members have primary care access, they're less likely to go to the emergency department, their chronic diseases are better managed, they're taking their medications. If they have surgery, they're hospitalized for shorter periods of time. So we have data around that primary care link. So medications and access to primary care, I would say, are two of the things that we're doing.
You referenced this in your intro, but with healthcare, it's always affordability, quality, accessibility, pick two. I think that was a really good way to sum that up. So what are you doing to help that access to quality care? What are the biggest challenges you hear from patients to actually getting something that will help treat what's ailing them?
Well, let's kind of uncouple those. I think the first thing I would say is access, and the elephant in the room for me, frankly, is the fact that Idaho is 51st in the country behind the great state of Puerto Rico in terms of clinician capacity. We don't have enough clinicians, and that's physicians, that's nurses, that's ancillary caregivers such as technicians and medical assistants. It's what we call mid-levels or allied professionals in terms of our NPs and PAs. We just don't have enough, and that's a system issue, and it varies to some extent by specialty. So it's harder to access primary care clinicians. It's really hard these days to access an OBGYN physician, particularly a perinatologist. The fallout from that is we're losing pediatricians as well. We know there's a dearth or a scarcity of behavioral health clinicians. So how do we then address that, I think was your question. So on the access side, number one, we have to ensure that there's access to medical education, right? We know that where people receive their medical education and when they're then trained after medical school, which is called residency, is where about 70% of people end up practicing. And we struggle with that. It's not going to be a political conversation, but we just struggle with it. We don't have enough seats for Idahoans to go to medical school in an affordable way, and we don't have enough places to train them. So that's number one. In terms of quality, I think, like Ed said, one of the things that we try to do is share data with our clinicians, as Ed said, in real time so that they can see, God, Dr. Meltzer's due for his X, Y, or Z, I better call him in, so that we are providing data in large measure to primary care physicians so that they know which patients, or in our case, members, need which services at what period of time, so that we can ensure that they're getting the information that they need. Because of APIs, because of technology, and because of, frankly, just emotional relationships, as Ed said, that didn't necessarily happen 5 years ago, but that ensures members get the care and the quality that they need. I'll pause there.
I'll just add to that real quick. Anybody live in Canyon County in here? You gotta be kidding me. Am I the only one? I am the only Canyon County person in this room? Well, okay, well, I'm the expert. In the Valley of the Blind, the one-eyed man is king. So the further you go west, the greater the access problem is. It's significantly west. Twice as more difficult to get a family practice physician, and the further west you go. And not only that, the further west you go, the fewer times we seek healthcare, which obviously is a major issue in terms of identifying disease processes early. And so that just leads to the escalation of cost, decreasing clinical outcomes. It's just a bad spiral there. And so getting access to physicians is obviously an extremely important thing, but prioritizing who needs to see the doctor is a big deal. If you're really sick, you've got a lot of chronic conditions, you may need to be seen once a month. In the old world, that would never be able to happen. Where we're going, those kinds of treatment models are becoming more and more financially feasible for us to do, which is right, because some people should only see the doctor once a year. But we've got to do a better job of making sure that the people who need to be seen can be seen quickly, and have the right motivation to be coming in and being taken care of. So that prioritization is something that we're really working on, and we're I would say we're doing a good job moving that ball forward. All the health systems are working on this, and it's an important priority for us.
Well, and to go off of that, as a health system, anyone who walks into your emergency room, you can't turn them away. You have to give them care. So how are you guys shuffling those patients and trying to get them connected to quality care outside of the ER that isn't as expensive?
Yeah, so a lot of education. I think in general, as Dr. Meltzer said, we've got people that come into the ED that don't have a primary care physician, and that's a major issue. When that happens, the physicians and all the clinicians work very hard to then connect them with a primary care physician if they don't have one, because generally speaking, a lot of the people that come into the emergency department really could be taken care of in an urgent care setting, or, and of course, in a primary care setting. If they had access and could get answers to their questions, get med refills and different things like that, they would never even show up in the emergency department. And so that's obviously a big deal. But we prioritize those folks. If they come in, they do not have a physician that is their attending primary care physician, then we work very hard to connect them. If we ask them a question like, do you have one? And they say they do, well, then we work really hard to connect them back with the physician that they have, because that's where the care should be initiated in the first place.
Yeah, and just to double click on that in terms of how we're working together, which I think is an important theme here, one of the nice things as the technology has evolved is that we are able to send messages both as clinicians to the plan and from the plan to the clinician, so that we know, because we know people get their care in all kinds of places. The other nice thing that we've seen kind of by happenstance or just by monopoly is that both the major systems are on Epic, which is the major electronic medical record. So it makes information and data sharing so easy. And just from an interoperability standpoint, which irrespective of your industry, we all know how important it is to share information with partners with whom you work, whether it's a supplier or a distributor, or someone, in Ed's case, that's actually doing the manual work. So that's, I think, another way that we've really been able to help direct care. I will say one of the nice things as a practicing emergency physician is more often than not, we are able to, if after we've completed the care episode, refer to primary care, we can often send them appointments, we send them phone numbers, or specialty care if needed. So that is one of the benefits that we have. But you're right, about 30% of the patients that we see in the emergency department are considered avoidable. That is to say, they have conditions that could be managed elsewhere.
Let's talk about what employers can do, because oftentimes employers are the ones that are buying these plans and figuring out what is the care going to look like. What are ways that they can partner with health systems like St. Al's to bring those prices down for their employees?
So again, part of it is education. I think we have a lot of really engaged employers in the Valley that are, I would say, are doing more and more to educate their employees about options. Some of that is coming through the broker channel. I don't know if we have any brokers in the room, but I just tell you right now that brokers are probably maybe one of the most underappreciated. Okay, oh, here's Cass. Hey. Oh, hey, guys. Okay, so sorry, I didn't see you earlier. So these guys are some of the most important, underappreciated, underutilized experts in the Valley when it comes to your health. And most health plans in the state of Idaho are sold through a broker. And so when that happens, those guys are experts. They're evaluating plans and working with the employers to make sure that the health plan that the employer chooses fits the organization really well. But they're also a great conduit to bring in education and continue bringing in more resources from both health systems. St. Luke's and St. Al's are phenomenal at getting into the employer space and then educating people about these are your options, creating relationships, so that way you know who to call if you get stuck, if you need a referral, or you're not getting an answer to a clinical question, or any of those kind of things. Both organizations are great at then coming back and going right to you and answering those questions. So my encouragement to employers is don't sit back. I mean, proactively reach out to the health systems and ask and get those questions answered. Bring them on site. Start developing those relationships so that then you know who to call, and then they can help navigate the system for you. I always say, you know, my friends and family, if they get stuck on a medical question or need a referral, or they can't get their primary care doctor to call them back, or something is going on, all they got to do is text me, and generally I can walk down the hall and grab the doctor and say, hey, can you please call my wife back? She's got a question. Anyway, but you shouldn't need someone on the inside like that, like a friend of the factory. Anybody, well, there's no Canyon Canopy, but you know Parma Furniture, a friend of the factory? You shouldn't need that, someone inside in the system to navigate that. But if you do have that through a relationship with your employer into the health system, that can greatly benefit you and help you speed up getting answers and referrals and appointments and all those kind of things.
Dr. Meltzer, obviously, if I were to ask you, you would recommend that employers go with Regents. But what is your advice to an employer that is trying to find the right insurer to have affordable plans for their employees? What are the green flags they should be looking for?
Yeah, look, I think it gets back to where we started around affordability, around quality, around access, and then that we'll talk about what we're sitting on, which is a four-legged stool, which is sort of service. Healthcare and health insurance is interesting in that we don't often think about it until you really need it. It's kind of like the emergency department. So we often lead with, I want to pay as little as possible. And believe me, I deeply understand that. But at the end of the day, we also all need a company and a facilitator and a conduit and a partner, to use Ed's term, that's going to pay the claims, right? Provide the right network, give us the service that we need when we're sick or someone of our family is, and have the right network. So I think those are some things. I couldn't agree more with what Ed said around broker, what we sometimes call producer partners, right, who are deeply savvy in terms of the dynamics of the market, in many cases take a more objective approach, and can be great advocates for particularly self-funded companies. And then the other thing is to know your population, right, and understand what your priorities are. You know, I'll get back a little bit to the access and quality thing. One of the areas that Regents has really doubled down on is, pick your term, you know, telehealth, virtual care, digitally enabled care. The reality is, because of our access challenge, remember 51st in the quote country behind Puerto Rico in terms of number of clinicians, physicians and delivery systems can't do it all. So we've had to leverage virtual solutions for things like behavioral health, physical therapy, right? Even cardiology. So Regents has really built a very robust sort of, think of it as a virtual network, of almost a virtual hospital, where members have access to behavioral health clinicians. It takes about, if you were to try to find an appointment with a psychiatrist today, on average, 6-month wait. So with these solutions, over 92% of the time, it's 48 hours. You can get a psychiatrist. It's really important if you're out of your medications, or you're psychotic, or your kid's severely depressed. Same thing with cardiology, really hard to get to see a cardiologist oftentimes. Physical therapy can be really challenging. So that's offering those kinds of solutions depending on your workforce may be really, really helpful.
And if there was a silver lining in COVID, like we were talking about earlier, you know, it taught us that we can work well with the insurance partners to then move forward in telehealth, remote monitoring, all those kinds of things that we do. And of course, that then lowers the cost of care to some degree because we don't have to have people in the hospital to get monitored, or we can discharge them earlier on remote monitoring and use the telehealth capabilities that we're developing to help continue to combat the cost.
Yeah, I'm glad Ed mentioned the pandemic, because I think one thing that's particularly relevant for this group is that, if nothing else, I think one of the things that we saw, learned, and felt, either personally or as a business owner, was this dynamic and connection between health of our employees and business continuity. It was never so stark, right, that if my employees are not, or I'm not well, right, the company doesn't exist, therefore I don't have a paycheck. And so when we start to think about, the insurance that we use or the systems where we get our care, I think healthcare has become more personal and more of a priority because we had this sort of existential moment kind of a couple years ago, either as individuals or as businesses.
You guys read my mind and anticipated my next question, which is, what are the ways that new care models, new technology is getting implemented, and how is it reshaping how we get our health care? I mean, it feels so different to go to the doctor now than it did even a decade ago.
I'll go first this time. So there's technology that we have invested in, we continue to invest in, and of course we're evaluating new technology all the time. There's no shortage of technology solutions. I would say there's a couple though. The remote monitoring one is a big one, because that literally takes someone and moves them out of the facility into their home or keeps them at home, and that's a really dramatic change in what we can do. And the clinical service is high quality because the amount of remote monitoring that can be done is significant. You've got eyes on you all the time. And so that's a really positive thing. Other more procedurally based technological advances include like assisted robotic surgery. Now, it's not just fancy surgery. The outcomes are actually better. So clinically, it's excellent, but recovery times are shorter, infection rates are lower, lengths of stay are lower, so we're discharging patients sooner. Outpatient surgery. I mean, I can't tell you the number of surgeries that we used to do 15, 20 years ago that would never have been considered outpatient. And now it's routine outpatient. Total joints, some spine, different really invasive types of procedures, but through technology, we don't have to keep you as long. And in some cases, we can send you home same day. They're total weight bearing, same day on a total joint. Would we have thought of that 10 years ago, even 15 years ago?
No, not
That's like, so I think now if they would consider you probably not healthy enough to have a total joint surgery if you can't go home same day. So the thinking is completely reversed, and that's through technology and advances with our proceduralists. So all those things, combined, begin to lead to, a lowering of cost, or at least an addressing of the cost situation that we're in.
Yeah, I agree with everything that Ed said. I think that the theme there is what I would call value. I know we're focused really sort of on quote affordability, but most of us don't choose our clinicians or who's going to operate on us just because they're quote the cheapest. We want to ensure value, right? Now, inexpensive is great provided the quality is there. I think that's the caveat. So we speak often at Regents about high value care. So as Ed said, if a patient can have a similar kind of surgery, a joint replacement, by the same surgeon at a facility which is less expensive, that's a win-win. Not only it's also a win for the delivery system because it frees up a hospital bed or an operating bed for the patient that needs it. Because back to the first thing I said, we don't have enough clinicians, nor do we have enough facilities. And Ed said that the further west you go, the worse it gets. So there's a win-win dynamic there. Same thing for infusions. Same thing to some extent for emergency department care. We have to move that upstream as much as possible to urgent care, to primary care, or to virtual care when and where possible. And then back to your question, how are we thinking about sort of delivering care differently? And what we talk about is sort of three rights, that you have the right care, the right place at the right time. Virtual solutions, again, as Ed said, the good news is most of us are more comfortable. And I think there's a misconception. My mom is visiting for Mother's Day, that older adults are not necessarily technologically savvy. That's not as true as it used to be because they want to stay in touch with their grandkids who are on social media. So, most older adults actually are pretty savvy, checking their medications, reaching a clinician, and again, that provides capacity for a system that desperately needs it.
Talk to me about value-based care, Dr. Meltzer. How are you guys incorporating that into your programming and how you're serving your clients?
Yeah, and Ed, I'm sure will riff on this as well. I think just so people are aware historically how healthcare has been paid for has been highly transactional, sort of you do something, sort of a pay for volume, kind of the more you do, the more you get paid for. And in some cases that makes sense, but the paradigm has shifted over the last really several decades and at Regents for probably the last 15 years in terms of what we call as paying for value. So aligning incentives, and I'll use some of the quality metrics, for example, so ensuring that patients are having their annual wellness visit. And this becomes even more important to some extent for those that are on Medicare because of how government programs are incented, but for all ages and for children included, ensuring you're having your annual exam, ensuring you're getting immunizations, ensuring you get preventive care screenings. We're paying for value so that if and when our clinicians, and we're feeding them data to say, hey, Dr. Castletine, did you know Mr. Meltzer is due for his, we are paying them for that service so that they're doing the right thing for the patient and they're getting rewarded for it. So it's aligning the type of payment with the right model of care and doing it with our clinical partners, not to them. So we work together and say, for example, some of my colleagues at St. Al's said, we're seeing a lot of patients in the emergency department for urinary tract infections. We've created a care pathway to move that. We said, great, let's build that into our quality incentive program. So doing it with them as opposed to them. So really it's a pay for value. And most of our contracts have shifted that way over the last decade and a half.
How is St. Al's approaching this?
Cautiously. I mean, it's true. So these payment methodologies have been evolving for quite a while now, actually. It's difficult when you have a foot in each canoe and, you are trying not to get wet, but at some point you realize you're just going to get wet. I think what we've done a good job of communicating with Regents on the data side to understand our population better so we know how to intervene upstream quicker to prevent disease processes from getting to the point where they're super expensive. So if you think about from a payer's perspective, you're working on a total budget. You've collected the premium, you have all the dollars, there are no more dollars. Now it's a matter of taking those dollars and then spending them appropriately to take care of the care, and hopefully there's something left over at the end to pay yourself with. Well, when the payers then work with us in that same environment and they say, okay, hey, St. Al's, here's a budget for total joint surgery, or here's a budget for COPD or heart and vascular or whatever it is, then the health system can say, oh, okay, well, that's the money we have. Now we've got to, how do we use that wisely? That's a completely different mind shift than a fee-for-service mindset where you get paid for every little thing you do. I mean, back in the day, we got paid for, an MRI for the total joint, and we got paid for doing the operation and the inpatient stay and the labs and the little fancy mug we gave you and all those kind of things. We got paid for all of it. But now, if it's on a total budget, then you got to ask yourself the question, well, okay, the first question is do you actually need a total joint? Are there other things that we can do for you way upstream before you need a total joint? When you start showing signs of needing a total joint, how do we intervene way up the line? Well, that's way better care. That's actually health care. That's not sick care. So that's where we're going. And I would say, I don't know how far into the process you'd say we are. I feel like we're 30%. I don't know what you'd say. 30% into the process. And we've got a long way to go. But what I would say, the good news is that we're on that road. So we're moving in that direction. And we've burned the boats. We're going. This is where we have to go. And as long as we have good relationships, good partnerships to do it, we feel like we can get there.
Several times you guys have mentioned how well you're working together. I mean, what are some ways that you could improve this partnership, or just health systems and insurers could talk to each other for even better outcomes? I mean, either one, go for it.
So I'll start. So I spent a couple of years with a health plan, and I found out something interesting, and that is that health plan leadership are actually a lot smarter than I thought they were. That's the first thing, a little bit of admission. I also found out that most of the ideas I thought were brilliant are actually illegal. You can't do a lot of the things I was hoping we could do when I went over to the health plan. Some of what we are constrained by is the law. There's some things we can't share in terms of data. There's some things that have to stay proprietary. I'm a very open person, and I would much rather just show you everything, and then let's just deal with the fact that we all need a margin to maintain our business. There's nothing wrong with a margin, No margin, no mission, right? So I don't have any problem with that, but we're needing to get more and more transparent with each other so we really know what's going on. So when I come to Regents and say, okay, here's the fee schedule that we have to have in order to pay all of our bills, have a little bit of margin to reinvest, replace things that are broken, evaluate new technology, the insurance side can trust that and say, okay, we know that that's true. Those numbers are legit. We can work with that. And then when they come back and say, hey, Ed, that fee schedule is too high. We can't come up with a competitive premium for that. I can trust them and say, oh, well, okay, then we've got to work together and come up with another model. So in my mind, it's no more difficult than building trust with people that you can trust what they say without having to see all of the data, because some of it we can't get access to.
Yeah, I love what Ed said. I've been an emergency physician I'm coming on my 25th year. Healthcare's never been harder. I think there are a lot of headwinds in terms of the price of goods, the sickness of the population, right? We're seeing a lot of people obviously moving to the state, on average age over 65, right? We're seeing consolidation in systems. We're seeing a flood of physicians leaving the state. But there's the kind of the flip side, isn't it, right? Never let a good crisis go to waste. And I think to some extent we saw that during the pandemic, where we realized, like, again, existentially, we have interdependencies. And the other nice thing about where we work is I think there is a spirit of generally of trust and what I call kind of compassionate innovation. And so I think first you have to trust who you're working with. You have to realize that you're in it together, that you are interdependent, right? And don't forget, we're all patients, so we need this care. I think, artificial intelligence, for example, which we haven't really talked about, how can we as a health system leverage something like artificial intelligence to be more efficient in terms of ensuring that clinicians can do the care that they need to and the systems get paid fairly and quickly? I think there's a lot of common ground there, leveraging the electronic medical record, building APIs so that we can connect quickly, talking on a more regular basis. I mentioned to Ed, we at Regents have a quarterly, what we call provider advisory board, where we invite system and medical leaders from around the state to just kind of talk turkey, like, what are the problems, right? Let's talk about prior authorization. Let's talk about the legislative environment. Let's talk about improving quality. Let's talk about how we measure physician quality. Let's do it transparently. I think that spirit is really important. And I think our state is pretty conducive to it because of its size. We're sort of small enough, big enough. One of the caveats, I'm just going to throw it out there, is how does the legislative environment necessarily align with that? I think is always going to be another piece we need to think about, and work collectively to surface the issues where there may be blind spots there.
Great. So obviously you say we're all patients. So what would your advice be to a patient who's trying to manage their own health care, and keep more money in their pocket? I'm interested to hear from both of you on this.
So since I'm not the doctor, I'm going to talk first because I know what you're going to say. Oh, I think I do anyway. This is the one area that if I was ever tempted to get on a soapbox, being a non-doctor, I would. To me, the biggest piece of advice, if we have the magic wand and we could wave it, everybody would have a primary care doctor. I literally, no hyperbole here, and I'm prone to it. That is the one thing that I think could really change medicine. It could change the cost structure. It could change the overall trajectory of the expense structure for both the insurance companies and the health system. And the reason is because, and you alluded to it earlier, when the primary care physician is the quarterback, everything is managed more appropriately. Costs come down, clinical outcomes go up, and it's a beautiful thing. The problem is that we've got to get people access to those doctors, and we're working on that, and we can do that. But here's the other part, and we don't talk about this very much. We probably should talk about it more. We should have an annual wellness visit. And in the past, I would have said, when I was in my early 30s, I would have said, not a chance. I never get sick. And then, well, I think I've changed that now. Maybe it's because I'm getting older. But I think everybody should have a primary care doctor for lots of different reasons. But everybody should have an annual wellness visit. Because in that annual wellness visit, you're going to hear things that are going to help you. I just had mine a couple months ago. Sam Battaglia, primary health, really great doctor. He's been my doctor forever. And he told me, he said, Ed, your cholesterol is in the good range. But have you ever had your doctor say something, you know something's coming right next? And this is one of those times, and he said, but it's higher than it was last year. He said, you're healthy, but your cholesterol is higher than it was last year. And I said, oh, okay. And he goes, and last year was higher than the year before, and the year before, and the year before. So he said, you kind of are going like this. And he said, at your age, that means in the next few years, you're going to have to go on a medicine. I don't remember which one he said. You would know.
A statin.
A statin. So now my choice is, do I make some changes or do I go on a statin? When it comes to lowering the cost of care, we have to be responsible as well. There are things that I need to do to make sure that I don't cost myself and the community money down the road. Now, genetics is undefeated. Of course, some of us are predisposed with all sorts of stuff, and we're going to have to deal with that. But there is a lot that we can control. Having a primary care doctor, going to them every year, doing what they're suggesting you do is super important.
Amen, brother. I couldn't agree more. And yet there's a lot of things conspiring against that, right? And we've talked about access. I think we live a little bit in a paternalistic society, right? Someone else pays for my health care, right? I want to eat fast food, and when I get sick, I expect everything. That is sort of the American way to some extent. And the reality is, as whether we're an employer or an individual, we do have to own our health care. So I think really a sense of ownership in terms of my health matters and what can I control. Generally, we can try to control what we eat, how often we eat, what we drink, how much we sleep, do we exercise, right? Do we prioritize our health and well-being? Do we think about health and well-being integrated with things like social determinants of health, where I live, the environment, am I isolated, do I have transportation, how do we help our neighbors think about that? How do we integrate behavioral health? And I think one of the good things on the other side of the pandemic is we've seen there's a little bit more of a spirit of people disclosing that behavioral health and physical health are interdependent. You can't really have one without the other. Oh, by the way, if you have both, they're 3 times expensive as if you have one or the other. So a sense of, I think, really owning it. And I think the other thing that employers can think about is how they structure their benefits, right? Incenting primary care visits. But back to primary care, right? We all would love to have one. We encourage you to get one, and yet we need more. So we need to train them, we need to retain them, and we need to pay them appropriately.
Great. Great insights from both of you. So, Ed, from a hospital's perspective, what should patients be doing whenever they are in your system? Beyond just those kinds of, you have walked in the door of the hospital, you're making these decisions. What advice would you give beyond just, living a more healthy lifestyle?
So I think, part of it is, I think, insisting on outpatient care when it's possible. I think that, there's lower cost settings of care. And this is one of the reasons why I'm pretty passionate about the partnerships with the payers, especially Regents, because they support us in that move. A quick example, we bought Salter's 10-mile surgery center. And so we bill it as an outpatient surgery center, which means it's a fraction of the price of an inpatient surgery. The costs are a fraction there, so the bill is a fraction. And that's just math. Well, you can already know that when we do that, we're turning loose of lots of dollars when we have all of our orthopedic surgeons and others go over there and do surgery rather than the main OR where the billing is, more. But we're doing that because it's the right thing to do, and people can afford that a little more easily. Outpatient imaging, anywhere where you can ask for an outpatient service. The question should be, is there a lower cost setting of care for what you've just suggested to me, Dr. X? And if there is, then you should ask, well, why can I do that? And generally speaking, I think the physician community will say, well, you can, and let's do that. I think so. Getting the community to ask those questions and pursue outpatient medicine is going to be important. I think interacting with your provider through the website. What's ours called? MyChart, of course. Is it MyChart at St. Luke's too? Is it
Yes.
MyChart everywhere?
It's
MyChart. Epic MyChart. Interact with your care team through Epic. A great way to establish a relationship. You can ask questions, they'll answer you. And that's another way to control your costs, because the answers they're going to give you are going to be cost-based answers. They're going to be helping you lower the cost of care.
On the flip side, Dr. Meltzer, I think we've all been there where we have insurance, but you're going, okay, how do I get the most out of this? What would you give advice to someone to best utilize those benefits in order to get the most bang for your buck?
Yeah, and we all love getting a 10-page EOB in the mail, right? It's hieroglyphics, and it's the reality. I think, Ed mentioned early on kind of technology, and I think one of the advents that we have seen is that websites and apps now are really better than they've ever been, and they continue to be refined, and more people, including my mom, tend to be plugged into them. And one of the roles that we see, one of the obligations that we see as a health insurer is to ensure that members, patients are educated or activated and motivated to do the right thing. So a lot of push messaging, a lot of price transparency. So there's, really more of a price estimator, because you don't really know, but cost estimator tools in terms of what things, where people can also look at where they are with their deductibles, where they can also look and see, I'm in Canyon County, I need a primary care physician, who can I know, by the way, I like St. Al's or St. Luke's and I want to go here. So helping to make that information transparent. And then as employers, encouraging our employees to register for their health plan's website and to track that with either your consultant, your broker consultant, or your health plan to ensure people are using it. There really is a ton of information that can be the good news and the bad news, and then coordinating that information. So again, we're doing it on behalf of physicians as well, and ensuring that physicians are getting the timely information that they need. But really as a member, I would say, it's a matter of understanding your benefits, being familiar with the app, and don't forget, you can call the number on the back, and there are really savvy professionals that are waiting to help you if you have questions.
Wonderful. Thank you guys so much. Just wrapping up, I'm interested to hear a forecast from both of you about what's ahead in terms of affordability, what we're going to be seeing on our bills, and then, what are some things that people like you guys are going to be trying to do in the future to reduce those costs?
I don't know, it's like the sky today. There's some sun, there's some clouds, there's a little bit of wind, it's changing direction. I think it's probably somewhat similar. I think our recent trends have a lot of upside, but they do have some, costs are just going up. I think the access issue remains real, but I also think it's to some extent like, let's not let a good crisis go to waste. At the end of the day, I think what matters most to all of us is our health and that of those whom we love. I think if we can come back to that and think about how we can get creative, I do believe the advent of technology, particularly some of the artificial intelligence, machine learning pieces, will make us more efficient. One example, I went to see my physician the other day for my annual wellness visit because I got a text from Regents telling me I was late. And, he sat the phone there and said, do you mind if we just have a conversation and I use this? He said he's able to see 3 patients a day more now because he's not clicking on the computer. Those kinds of things will breed efficiency. I think we're going to continue to see unbelievable scientific breakthroughs. I'm not going to make a political comment. Hopefully in terms of medications and so forth, how are we going to pay for them? Right, so there's some really challenging things. I think some of the comments Ed made around shifting site of care continue to remain really vibrant, but yet we have to think about how do we provide access to that care, west of Boise.
I'm a glasses half full person, so I tend to think about the people that are doing the work. I was thinking about on the way over here, I think I know all the executives at Luke's for sure, and at Al's of course, but also at all the payers. And there's a lot of really good, well-intentioned, smart people that are working very hard to address these kinds of questions. The headwinds we have are significant. There's no question. Just the chronic conditions that are unmanaged is a really significant problem, and it creates a lot of downstream consequence from that. But the models of care that we are pursuing with our partners on the payer side of things are showing signs that it will work. We just need to keep going. I think that when it comes to decisions that we make now, I think choosing a health plan that has a great network, it used to be the larger the network, the better the access. Now it doesn't matter what size your network is. It's just, if you have access, it's because the people that are in that network prioritized access. So I think the more we do that, the more we prioritize those kinds of things, and then continue to educate everybody, especially the employers, and how they can interact with us to lower their cost and be proactive in that. To me, those things will continue to show promise, and the more we get momentum behind us and the volumes shift from more fee-for-service into more value, then we'll cross that. Now, we've said for years, let's bend the cost curve. Everyone's bend the cost curve. I don't know if we can bend the cost curve. I have no idea. But surely we can flatten it, or we can slow the rate of growth. And even those things, I think, are going to be very welcome to our community.
Thank you everyone so much for coming. I hope you guys enjoyed our event. We also want to give a big thank you to our panelists, Dr. Dan Meltzer with Regents Blue Shield of Idaho and Ed Castledine with St. Alphonsus Health System. Thank you guys so much. Also, a big shout out to Freeform. They provided our furniture for today. And thank you to Free Spirits Beverage Co. for the delicious mocktails and drinks. And of course, a big thank you to our sponsors, St. Alphonsus Health System and Regents Blue Shield of Idaho. Thank you guys so much for coming.